Hi everybody, welcome to the Facebook Live. I am sitting with Dr. Gassman from PRMA in San Antonio, Texas. My name is Terri Coutee and I'm the founder and director of Deep Sea Foundation. And I'm really excited that we can be in the PRMA space today, Dr. Gassman, during Breast Reconstruction Awareness Week. It was a great day yesterday. We had a great celebration last night, providing education and talking to patients and so forth. But today I'm very excited about the fact that we're going to completely repurpose this video for not only the PRMA Facebook Live. They're going to use it. I want you to watch for it on their YouTube channel, all their social media accounts. It will also be on the Deep Sea Foundation YouTube channel. It will be part of the Deep Sea Journey podcast. So we're going to just use this for a lot of educational purposes today. And so I'm really happy to be here. So thanks for joining me, Dr. Gassman.
No, my pleasure. It's great to talk to you about what we do, helping people, overcome their difficulties with their breast cancer journey.
Yeah.
And really restoring them to how they want to be.
Yes. Yeah, we're anxious to talk to you today and have this discussion. So in autologous breast reconstruction, or in DIEP flap specifically, there's a lot of terms I feel that patients just aren't aware of. And so we're going to talk about one of those terms today that I learned about since my own DIEP flap here at PRMA in 2014, and it's called the high definition DIEP. But you know what I'd like for you to do first, Dr. Gassman? I think there's maybe, well, at least in my mind, there's three types of reconstruction. I think about autologous reconstruction, which is using your own tissue. That's what I had at PRMA DIEP flap. There's implant reconstruction, which is, either a saline or silicone filled shell. Mm-hmm. And then I always say there's a combination of the two. Mm-hmm. So some patients use autologous and implant reconstruction. So I want you to kind of begin and talk to us about the definition of high-def DIEPs to help them get an understanding of what exactly we're talking about in terms of autologous tissue reconstruction and DIEP flaps.
Okay. So I have spent quite a long time doing both breast reconstruction and body contouring. And I had noticed that there were a number of patients that were quite dissatisfied with their end result from many circumstances, because the final shape and contouring of their body in both their donor site of wherever location of their own tissue really wasn't kind of matching with where they had hoped and the expectations. And with that sort of background and approach, I wanted to develop something that would allow the patients to have not only a great overall breast shape at the end of their reconstructive journey, but frankly a donor site that they were proud of, happy to have, not just part a necessary toll to pay, but actually something that was another feature of their body that they enjoyed and helped them regain confidence. Mm-hmm. So to that end, in the field of plastic surgery, there's a growing interest in high definition body contouring procedures, which I've learned. And I wanted to apply that to our patients so that they could reap some of those same benefits. And in doing so, that allows us to really benefit not just the overall aesthetic of the reconstruction, but also the quality and the end result of the breast and the donor site.
Mm-hmm. Yes, because there's some terms I learned in plastic surgery from all of you And one of the terms that always sticks in my mind is form and function. And this is part of that. So I'm going to interject here because this is one thing I would like patients to hear from another patient perspective. You are talking about your training and background in plastic surgery, and it's a step-by-step procedure. So I'm telling patients this for a reason. You know, Dr. Gassman, you went to medical school, then you chose to go into plastic surgery, but with Dr. Gassman and the team he works with at PRMA, they have also chosen to do further training in microsurgery. So when you look at the step-by-step progression of medical school plastic surgery and then microsurgery, it's like you said, you're combining all of those. So here's something in my mind as you were talking, I was thinking about, as a patient who's had breast cancer twice, when patients come into you, whether it's for breast cancer, an active diagnosis, or they're through with their treatment, or whether they're facing a high risk of getting breast cancer due to prophylactic, in my mind, a message I'd like to give to patients is, as a breast cancer patient, sometimes we think we just want to treat the cancer and everything else kind of gets set aside. Patients know that you're going to a trained plastic surgeon who deals with aesthetics. So they always treat the cancer first. That's always number one. But you have to keep in mind, you're here with a specialist for a reason. There's absolutely no reason they cannot ask aesthetic questions to get the optimal outcomes. I'll leave it at that, but I was thinking about that as you were saying
no,
it.
I mean, it's there. The whole experience is really, as I say to my patients when we're really discussing the benefits and risk of any procedure, I tell them, you're the boss here. Whatever, like, I'm your agent while you're asleep to carry out what you want. And you know, the aesthetic and the appearance of your body afterwards is a strong consideration, because when you wake up, you look yourself in the mirror. You got to look at yourself in the mirror, and you want to make sure the person you see in the mirror is the person you see in your mind.
I like that. You're the agent while we're asleep. That's really good. Yes, and I think also that patients have to learn that this is a process and they have to be patient with the recovery process. Okay, so to that point, let's go in a little bit about some of the key components of the high definition DIEP. There's a lot of details to it that I think you can tell, you know, our viewers and our listeners about in terms of the recovery process, but also before we even get to the recovery, I'd like to go in a little bit about the absolute logistics of it that you do in the OR, if you don't mind.
Sure.
Yeah.
So with this, when we've met with the patient, talked about the benefits and risks and all that, we've discussed what is reasonable, and we've then begin our day. We design the skin paddle and the area that we're going to take and donate from the abdominal area to the breast. We make slight design changes that allow us to recruit just a little bit more tissue that helps in terms of volume for the breast, but also helps push the final closure of the abdominal incision in such a way that it allows shaping of the donor site.
Yeah.
And once the tissue has been transferred, microsurgery has been done, and the breasts have been reconstructed, and we're turning our attention to closure of that donor site, there's some additional procedures in terms of how we close the abdominal donor site that allows us to define key elements of the abdominal and torso area that a lot of our patients are interested in. And those would include narrowing of the waistline, defining the musculature of the abdominal wall to a certain degree, just so there's just the ever slight appearance of the side of the six-pack muscles, or maybe even a little bit down the middle, but not each individual muscles and that sort of thing. That's a bit much at this point.
Right, right.
But some general overall defining characteristics that allow us to close the abdomen with less overall tension, but greater overall aesthetic and definition.
Yeah, we so often talk in, the term is breast reconstruction. So we so often talk about the aesthetics of the breast, but what you're talking about in a feminine body, I'm talking from my own standpoint as a patient, as a woman, there are those defined curves that we look for. So that's a lot of what you're talking about, I think, from what you're telling me.
Yeah, it was my hope when kind of formulating these ideas that the donor site would be as good as the final breast reconstruction, and not an innocent victim here of what it's donated, but an active participant in the overall aesthetic of the patient's body during the recuperation.
I love that wording. It's working together, the breast and the torso. Because look, when you have autologous breast reconstruction, you really are talking about the area from the top of the breast to the pubic line. We're not just doing the breast, it is an overall system. So I love the way you worded that, Dr. Gassman. That was very interesting. Let's talk about, I'm just going to ask you a very general question. Is everybody a candidate for high definition DIEP?
Not everybody, and that will come down on a case-by-case scenario between patient and surgeon. Some of that has to do with a patient's body habitus. Some of it has to do with, frankly, the surgeon's training, experience, or even comfort with some of these additional procedures. And that sort of interaction and intersection is, I think, what leads to the best overall result.
Yeah. So then what about, is there a specific BMI you look for? I want to go back to a word that you said, though. I want to go back to a word before we go on with that. You used the word body habitus, which is another term I learned in the world of plastic surgery. So for patients, basically your body habitus is your physique, what your build is. Can you maybe go into that a little bit before I ask the next question?
Sure.
Body habitus. Just tell us about a general overall term of that and what you look for. What do you see in different physiques? Because I think it'll help with this conversation.
Yeah, there are patients, I'd say fortunately many of our patients that are active. They're fit people that may carry a little extra weight, may have a little extra skin, from life and childbearing or many other reasons. That if that extra skin and tissue was removed, a lot of their effort that they've spent in good overall health and exercise would be apparent. Versus there are some other patients that they just carry weight and tissue throughout their body. And when evaluating a patient, those patients where we're operating on the front or anterior portion of the torso, where we can really affect a lot of change at the same time as the breast reconstruction, those are the patients that would benefit optimally. Now, those patients where to do their bodies justice, we'd have to operate on their entire body 360 degrees, that becomes a little bit more problematic in how we're able to do that at the same time as a microsurgical breast reconstruction.
Correct. So you know what I think of, even in my own family, and I think this is what you look for when you're having consults with patients. I mean, we have different heights. My sisters and I have different heights. We even have different widths, and I'm talking too in terms of the length of our waist. You know how some people say you're long-waisted or short-waisted? Do things like that come into play when you're?
Oh, they do.
Yeah.
Yeah, I mean, it's not uncommon for us to, unfortunately, for us to operate on entire families. And we see differences between those family members. And, individuals may have different sort of physiques in terms of how long their torso is in proportion to the rest of their body.
Right.
But that's something that I think is really critical in our design process and how we actually create the design for the tissue that's being donated to the breast.
Yeah. So now I'll go to the question about BMI. This is a good segue. Do you look for a particular BMI? Is that out of the equation, or?
So that the cutoff specifically for breast reconstruction and even more specifically for high def deep really go hand in hand, and those really don't change. We have certain cutoffs where above those numbers we know that there's a statistically increased risk for significant wound complication. And so part of our responsibility is that during surgery we have to steer our patients away from harm. And even though it's difficult on the front end, we know on the back end it's much safer and healthier for our patients to make sure that those sort of guidelines are adhered to, so that they avoid things that can slow down other treatments such as chemotherapy and other sort of elements of their overall care.
Right.
So specific numbers, BMIs over 40 within our practice are absolute contraindications to immediate reconstruction.
Right.
And delayed reconstructions are a BMI over 35. And that's just our thresholds in terms of wound complication.
Yep.
Now, a lot of the patients that we end up doing high definition deeps on are anywhere from the mid 20 to even up to 35 BMI. It's really more on a case-by-case scenario, and frankly speaking, it's how people carry the weight on their body.
Yes, distribution and how they carry it. Yeah, yeah. Do you guys use? I know that there's a wound vac system. Is that used frequently with the high def deeps, or is that again a case-by-case?
I use it quite often. So we use incisional wound management systems, and these are vacuum devices that are used on closed incisions. Historically, wound vacs were used to help manage open wounds for prolonged periods of time, but there's a growing body of literature that has shown that incisional wound vacs have very good outcomes, I should say.
Yeah.
I first published actually on this sort of topic, about a decade ago, and
Really?
more recently, yeah.
Okay, you're gonna have to share that paper
Yeah,
with me.
yeah.
So want to read that.
Yeah. So, and there are many benefits, but once again, that goes back to the interaction between patient and surgeon. And if a patient finds a surgeon that has very good outcomes and doesn't necessarily use it, I would say that a patient should also not demand that happen. That if that surgeon has a winning recipe, then just go with that.
Right. But the fact of the matter is, today, all of this conversation we're having, the terms, I think, are the important thing that I want patients to focus in on. Why not ask about high definition deep or more body contouring as they go through breast reconstruction if they're doing the deep flap? Asking about things like a wound vac system to improve wound healing after surgery. So I think they're just terms. It doesn't mean that everyone is going to necessarily have these procedures in place or use this equipment, but why not ask?
Reasonable.
Yes. So how did you get interested in the specific training that it takes to do microsurgery, Dr. Gassman, if I might ask?
No,
I can see you're very passionate about it.
That's a great question. So when we train in plastic surgery, we talk about something called the reconstructive ladder or reconstructive elevator. And it basically helps describe the many facets in which one can help deal with a surgical problem. And when I was training, the highest rung in that ladder was microsurgery, and at the time not everybody was well equipped to do those procedures. And I wanted to be able to offer everything to my patient so that I wasn't necessarily limited by my own skill set or my comfort or my availability of resources. It's really whatever the patient required.
Yeah. Okay. Well, because we're doing a Facebook Live, I want to focus my attention over on the wonderful person behind the camera today. Do we have any questions coming in at all? So we're all good?
Nope, just one lady that suggested pictures or drawings, if you have any drawings. I know you draw a lot.
Yeah.
I have white paper. Now, for those who are listening via the podcast, you won't see this, but I think Dr. Gassman has been so good about explaining everything as we're chatting here that maybe he can go through his drawings. Do you want to do this, Dr. Gassman?
Sure.
I'm handing him a pen and paper for the listeners who are listening on the podcast today, so I will let him define his illustrations as we go.
Yeah.
All right, so what I see him drawing right now.
It's like Pictionary, right?
It's like, yes. So what I see him right now is drawing the, I'm kind of jealous of his art skills actually right now. I taught school and the students never wanted me to draw because they couldn't tell what it was. I can already tell what this is. He's drawing the outline of a woman's body. And I see the belly button. He's drawing the elliptical shape of the DIEP. We're going to show this to the viewers in just a minute. We have a breast shape now. And
I was a little tilted when I did this.
That's okay. I didn't hand you very good equipment. I think you're doing amazing. This is drawing 101 for me.
Do you want to answer another question while you're drawing?
Yeah, sure.
Is repair of diastasis recti available during this procedure?
Yes. Yeah, diastasis recti. That basically is the separation of the rectus muscles or the six-pack muscles. And coincidentally, that's part of how we actually close the abdominal wall. So it's just incorporated with, and so it makes it easier. The actual act, I don't like that. I'm going to do this over.
I do have an extra sheet under for you.
Yeah, so the closure allows us to help, the terminology is obliterate dead space, and it sounds terrible. But
well, obliterate means get rid of.
Yeah, so we're getting rid of any potential space that fluid could collect, and it helps minimize the time in which drains are in place. So it really has like multiple benefits all at once.
Is it just women who have had large pregnancies, like my two, I call them my bowling ball children, my bowling ball boys? Is it just women who have had very large children in relationship to their overall physique that get diastasis recti?
Not necessarily, but it's definitely a risk factor. The analogy I give folks is that while the child's in the abdomen, you can imagine that the rectus muscles are like the staves on a barrel.
Yeah.
And as that barrel gets expanded, the barrel staves spread out. And a lot of the abdominal wall retracts, but sometimes not all of it. And if that is the case, then the separation between those two muscles are what we go after.
Yeah.
So in brief, what we do is we focus on narrowing the waistline. Sorry, I'll draw this so you can see it better.
Mm-hmm.
We narrow the waistline, and we also define the hip by bringing the waistline in and down.
Okay, so here's the waistline area, arrows going in to define the waistline, hip line here. This is the curve that I think about right in here, that nice curve that we get with a little bit of more contouring.
We put in sutures that obliterate the dead space.
Mm-hmm.
That can help the diastasis. That's also how the center part of the muscle is defined.
Mm-hmm.
And then the outer part of the muscle can be defined as well.
Recovery about the same for this?
It's about the same. So we live in a great time in as much as we use nerve blocks that effectively numb the area for the same duration.
Yes.
So it really takes the edge off.
I can tell you, yes, 100% it does. I have those nerve blocks and they're wonderful.
Yeah.
I have another one. How many, I don't know if she's referencing high def deep or regular deep, but how many of these procedures do you typically do a year? I know as a practice it's an average.
Yeah. I was like, yeah, it's like 260 something.
3 days a week.
Yeah, 3 or 4.
Yeah.
Yeah, I have 4 bilaterals this week.
So.
A couple, more than a few.
That is an excellent question for patients to ask,
Yeah.
is how many of these procedures you do, and also the success rate, which means basically, success rate, how do you define that? Well, I always tell patients it's the number of, it's kind of almost a opposite thinking.
Yeah.
It's the number of flaps you don't lose.
Yeah, exactly. My phrase during consultation is we're defined by our failures. So yeah.
Which are very few. Your percentage rate is 99% or more.
Yeah.
Yes, that's a very good number. What are we missing, Dr. Gassman? Is there anything, what sage advice would you give to patients who, because we know not everyone comes to PRMA, and certainly not all of my listeners and on the podcast, they're going to be listening from everywhere, as they will with the PRMA site. But let's say they can't come to PRMA, and you just want to give patients some sage advice on what to ask at a consult in terms of, let's say they go to a practice and they don't even use the term high def deep, but yet a patient wants to optimize the donor site. What sage advice would you give?
I mean, I would literally tell the patient to ask that specifically and say, what does the surgeon do to optimize the donor site, to make the donor site as good as it can be, and make sure that it's not an afterthought and not, frankly, just a means to an end. That's my philosophical approach, but I think having that conversation is an important step when trying to select a surgeon and figure out options of what that means. Now, not every patient's going to really, I guess, need or want to ask that question, and that's their preference.
Right.
But if it is important for the patient, then that is more than a reasonable question.
Yes. I think that it helps, again, speaking as a patient, to really think about what your lifestyle, what your preferences are, when you're in the midst of a cancer diagnosis, it's hard to kind of project that. But think about beyond the diagnosis. What does your life look like before cancer? What do you hope that it looks like after cancer? And I'm talking about what you want your body to look like and the activity level that you want to get back to, whether it's your work, your lifestyle, going to the gym. Do you have children at home? Are you an active mother? what is your profession like, and how much physicality does that take too? All of these questions to me are a self-assessment, even if it only takes you 30, 45 minutes to an hour before you come to see someone like Dr. Gassman. You're doing yourself a favor by doing a self-assessment and writing down notes to ask the doctor, because then this is called the shared decision-making conversation. I feel like I'm kind of having one with Dr. Gassman today because it feels so comfortable. But it opens up the conversation, and then you become a partner with your plastic surgeon. It becomes more of a decision made together rather than, maybe a patient coming in and thinking they're going to be told what they should do.
Yeah.
So, all right. I think I am thoroughly jazzed about being able to interview you about this today. And not only that, to do it in person. I usually Zoom these interviews, but this was very special today to sit side by side with you at your practice during Breast Reconstruction Awareness Week, to be able to have this Facebook Live, to ask these questions, and to have this discussion about a new term that I learned, which is high definition DIEP. I hope we spread the word about this, and I'm really glad that you're promoting the term. You discussed it with us today, so thanks for joining me.
Oh, my pleasure.
Yeah.